Hi, good evening, everybody. Dr. Sandeep from medical team, and good evening, Dr. Yogesh. Hello, good evening, everybody. Uh, Dr. Sandeep from medical team, and good evening, Dr. Yogesh, Ashutosh, Kiran, Sunil. Amit.
Uh, Dr. Sandeep, hello. Ashutosh here.
Hi, Ashutosh.
He's having some challenges because his video is not on. So
Uh,
maybe
see,
he's
we
retrying it. So let him connect.
yeah,
Okay.
even today I'm facing a lot of problem. Not able to connect from my
Yes,
laptop,
yes.
so I've connected from my phone now.
Yes, yes. So doctor was on, but now his screen is not visible. So I think he's retrying to log in. So just for a
Okay,
few
okay.
minutes, when once he log in,
Yeah,
we
yeah,
will
yeah.
start again.
Okay, okay, perfect. Yeah, yeah.
Just text him once he's ready to,
No, I've already messaged him. He would be back soon.
dear all, very good evening. I am Kiran Singh from Abad International Business, the marketing function. On behalf of Abad, it's my profound privilege to welcome each one of you. Since today's speaker, Dr. Yogesh Neupane, is busy with some network challenges. Once he comes back, I'm sure that we're getting to that. And I sincerely thank all of you for joining this session. And objective of such sessions is always like that, to have updated information from our eminent personalities like today's speaker, Dr. Yogesh Nepane. Uh, Please bear with us because of some technical clinches. You might have to bear for 5-10 minutes because some local area network challenges is there in his area. So I once again thank you all, and I wish that all of you are happy and healthy and safe during this pandemic. So looking forward for great participations and looking towards the great interaction with Dr. Yogesh Nepane. Yeah, he's here. So, so technical clinches are, I think it's over now. And I further this, I will request Dr. Sandeep, once Dr. Yogesh is on the screen with the slide, please take it ahead. With the introduction, though he's a big name itself in the Nepalian outside, doesn't need any introduction, but I would request Dr. Sandeep to take it, the introduction of Dr. Yogesh Nepane. Dr. Yogesh, can we start?
Because I can see. I think you can see me, but I cannot see you people. So maybe some technical hinges is still there. Just give me a 2 minute, okay? Just give me 2 minutes. Is it okay? Just I'll close
Yeah.
now. Okay. I'm a presenter right now. Okay, there is no issue. So I cannot share my slide. I think it will take 1 more minute. Share my content. Yeah, I can do this. So I'll open my slide, one slide, and I'll just try to share it. Okay. Mhm. Is my slide visible to everybody? Is it
Yes, yes,
visible?
yes.
Okay, is it visible, right?
Yeah.
That's great. That's great. Okay, I'm fine. I'm fine. Okay, Sandeep, can we start?
Good evening, everybody. Am I audible?
Yeah. So you are very nicely audible.
Yeah, perfect. Good evening, everybody. I'm Dr. Sandeep from Abbott Medical Team, and at the outset, I want to welcome all of you for today's session on the diagnosis of vertigo. For this, we have very special person with us today. So he doesn't need any kind of introduction. So one of the very well-known personality in Nepal. So currently, he's practicing as a otorhinolaryngologist and head neck surgeon in the ENT and head and neck surgery department of Tooth Kathmandu. Currently, he is the executive member of Nepal Health Research Council, Government of Nepal since 2017. General Secretary of Society of Otolaryngologists of Nepal. He is editor in chief of Nepalese Journal of ENT and Head and Surgery. General Secretary of Nepali Society of Sleep Disorder, and he is organizing secretary for SAKI NT Congress for 2020. He has taken training from different countries. He did his fellowship in snoring and sleep apnea surgery from Singapore General Hospital. He also attended a few of the key robotic surgery workshop in Singapore, and apart from that, he had training in diagnostic and therapeutic neuropathology, and also attended the British Academy Conference in otolaryngology in 2012. Because he is a very academically oriented person, he has conducted many workshops in different therapy area of ENT. So he has conducted workshop in vertigo. He then temporal fifth international Sudan overall headache neck conference. He was a faculty there. Um, and a few of the workshop he conducted on temporal bone dissection and the middle ear surgery in Nepal. Apart from that, he has been invited in many of the national and international conferences as on date, and very importantly, he has around 14 publication till now on various aspects of ENT. So, without wasting much time, um, I want to welcome Dr. Yogesh for this very interesting and very common but very complicated topic of management of vertigo. Welcome you, sir, and welcome everybody. And we're eager to listen to you, sir, on the vertigo management part first. Over to you, sir.
Okay, thank you, Sandeep. Thank you. Is my screen visible to everybody right now? Is my screen visible? This diagnosis and of vertigo made easy. Is it visible?
So we can see you, but we can't see the slides.
Okay. So I'm getting some hinges here. Okay. Okay. Just let me reopen it again. Okay. Okay. Can you see it right now? See it right now?
Yeah. We can see the slides. Yes, slides are visible
Okay.
now.
Okay, slides are visible. Okay, so good evening, everybody. Today I'm having some technical problems. Maybe in my area the network is not that good, and I'm trying to use a hotspot of Nepal telecommunication. So maybe some technical hinges will be there. But today, because it is okay, so today because it is Eid, And I wish a happy Eid and Eid Mubarak to everybody. And I'll try to make this presentation a very short so that people seeing us from Bangladesh and Pakistan will enjoy Eid. Okay, so this is a webinar which doesn't have a financial support, and this is absolutely for academic purpose. But some of the talks are influenced by Dr. Anirban Bishwa's talk because he's my mentor in neurotology. So you may see some similarities. And few videos are taken from the Google's absolutely for the academic purpose. So we and About has planned a neurootology series, and this series will be consist of at least of 6 to 8 sessions. Today, and the series will have basic concepts, history taking, clinical examination, investigation that is required in vertigo, and management of the common cause of vertigo and few complex cases. And this is absolutely supported by Abbott for academic purpose. Okay, so what is a roadmap for correct diagnosis? So how do you diagnose vertigo very correctly? So the roadmap goes from history taking, clinical examination, and investigation. And you can see the size of the font of this. History taking is big font. So it has got important role. Then comes the clinical examination. Then investigation has got very limited role for me. Okay, so I always like to share the slide. So what is the scenario of patient with vertigo? So patient comes with the complaint of vertigo and talk to a doctor. Doctor, please help me. And the doctor will see the patient for a few minutes and advise, and normally will say, okay, you do this investigation, take these pills for a few days and come back with a report. And the patient get this list, done everything by one physician or by next physician, and end of the day he will be completing all this. Then, but the irony of the patient is that everything is normal. So the patient becomes so frustrated that his every investigation is normal, but there is no explanation to his diagnosis and no improvement to his condition. So but the clinician problem is also that there is a vague symptoms of the patient. So there is a vague symptoms of the patient, and the clinical test and investigation has also very low sensitivity and specificity. So finally, this age-old photographs becomes very real, that the patient come back with every normal report and he's coming for the second time to our clinic. Then this is a patient, this is a doctor, because we have to hide it out because we cannot see what is going on wrong. But this patient, see, is suffering from disease. This patient is every report is normal, but he is having this sensation. See, he is having this sensation. So how can he believe that he is normal? How can he believe? Report is being normal, but he is normal. See how he feels. So see how the patient with right beating nystagmus feels. If we see the whole world with right beating nystagmus, it will look like this. His investigations are normal, but see how does the world looks for him. Left beating nystagmus, how does the world look for him? See, this is. So he has got all the investigation done in his pocket, but this is how he is suffering. So the patient, so this is a patient with vertical downbeating nystagmus. See, how can he be normal? So his investigations are normal, but he is not normal. Then the patient start to do a doctor sort, or the patient is referred from one department to another department. The patient will move from physician to neurologist to ENT, orthopedics, physiotherapist, psychiatrist in search if there is somebody who can cure him. Then we being a very sometimes we have to answer to other patient. The most simple answer is that cervical spine. So we search something. So patient is 40, 45 years old. Then we do a cervical spine X-ray, and there are some degree of spondylitic changes in his cervical spine. And we tell the patient that your problem is cervical spondylitis. And either we send the patient for physiotherapy, or we send the patient to use a cervical cord, or we give him the medication that is changed from one brand to another brand. But the patient is still not clear. So basic concept of balance system is very, very important that we are going to talk today. So we all know, because we have been taught this. We are still teaching our MBBS student. We are still teaching our postgraduate student that how our body maintains the balance. The body maintains the balance, that is position of the body in relation to the ground and surrounding, is maintained from the information from three sources. To vestibular labyrinth, it sends the information to the brain. To eyes, it sends the information to the brain. And the information from the peripheral receptor, that is sensory receptor from the muscles, limbs, joint, trunk, is sent to the brain. Brain, it will understand this information. The brain, it will understand this information. It integrates all the information received from all the system. Then it modulates the motor response. After understanding those impulses, then the brain plans to modulate the motor response. The cerebellum, it does the fine tuning of the motor response, and the cognitive system, it defines the nature of the motor response. Finally, all this system sets up very accurately, timely, and perfectly coordinated reflex action to two group of the muscles. That is, one to the vestibulospinal reflex to the skeletal muscles of the limbs, neck, and trunk, and second through the contraction of the extraocular, through vestibulo-ocular reflex contraction of the extraocular muscles. Means they set such an impulse so that our whole the body, is vestibulospinal tract, is also controlled, and extraocular muscles is controlled. Finally, our body maintains the posture despite any change in the surrounding or in relation to the subject position. But if all the system is also normal, but the cognitive system is very important. This guy is standing on a wall which is high, is 3 bricks tall. But the breadth is only one or two bricks. This is also same thing. But suppose when same guy walks on the wall, which is about 20 bricks tall, he's supposed to fall. The guy is same, the width of the brick is same, but the cognitive system now is playing differently. So we should assess the cognitive system also very nicely. So what does all this balancing system does to maintain the balance? So what does this do to our body so that we maintain the balance? The most important thing is that it does a gaze stabilization. Means it maintains the stable and clear image of the surrounding that comes to our eye. Means I'm saying something, so that image is very stable in my retina. So it is not moving here and there. If it is moving here and there, then I feel dizzy. So one thing it does is a gaze stabilization. Second thing that it does is a postural stabilization. Means our posture is maintained, body posture. So it's like our posture is maintained. We walk, we dance, we run, we sing, everything activities. Our posture has to be maintained. So second thing it does is a postural stabilization. One is a gaze stabilization, that image is focused on our retina. Second thing is a posture stabilization. Our posture is maintained. Third thing is that though the image is focused on the retina, but it helps to maintain the vertical and horizontal orientation of the image. Suppose the image is like this, but if my IC is like this, it is, or if my IC is like this, it is not good. So the graviception is also very important contribution by the balancing system. Means the image is oriented perfectly in the vertical and in the horizontal direction. So how does it is maintained? Gaze stabilization is maintained by the oculomotor system. with the help of the vestibulo-ocular reflex, smooth pursuit system, saccadic system, optokinetic system that we are going to talk later. Okay, the postural stabilization is done by the vestibulospinal system reflex, and the graviception is done by the ortholytic organ through the maculospinal reflex and maculo-ocular reflex. We are going to talk each and everything. It may look complicated, but it is so simple. Okay? This is so simple. So what is the oculomotor system? It is a simple system which helps to fix the image of the surrounding or image of the horizon to our most sensitive part of our retina, which is known as a fovea. Means the image stabilization is done by the oculomotor system with the help of the vestibulo-ocular reflex, saccadic system, convergence system, smooth pursuit system, optokinetic system, and it is a very complex system involving the very many mechanisms. If there is any problem in this system, then we will feel central vertigo, and the cause will be the central vertigo. So what is vestibulo-ocular reflex? Number one, reflex. So vestibulo-ocular reflex is a reflex mechanism for gaze stabilization, and it is one of the most important functions of the balance system. So vestibulo-ocular reflex helps to stabilize the image in the retina, that is fovea of the retina, when there is a visual target and when head is also moving and visual target is also moving. So it helps to maintain the image on the retina. That is a vestibulo-ocular reflex. How it helps? The vestibulo-ocular reflex comes into action when I'm looking at somebody and he is moving away, or when he is there and I'm moving my head, or when we both are moving. Suppose I'm looking as a stationary object. See, I'm looking as a stationary object and that image of the object is fixed on my retina. But when I'm suddenly move my head, that image also has to be fixed on my retina. If that cannot be done, that image will slip away from my retina, then I'll feel a vertigo. See, simple picture. See, I am moving the head of this girl. See, you can see her cornea. I'm moving her head slowly. See, still her cornea is in center. And see, or ocular muscles are contracting or relaxing, but it is keeping the cornea in center. So that my image now is in a more sensitive part of our retina. So that it is stable. So that is a vestibulo-ocular reflex. Okay. So what is retinal sleep now? So when the see here, this object is seen in the center. Now suddenly the head is moved towards the left side, but still the image, you see, the cornea has moved towards the opposite side and the image is fixed. But in a second, see, the head is moved, but image is missed here. The person has already moved his eyes to that side, but the image is mixed here. Again, he try to refix it. In that sense, the person will miss the image. Okay, so that missing of the image, sorry, so that means when the subject moves his head and if the image slips out of the fovea, that is known as a retinal sleep. And that retinal sleep, because the object is now not there, again trying to come back, so there is a movement of the object, so there is a blurring of the vision, and this creates a vertiginous sensation of the patient. Okay, now how does a saccadic system help? So saccadic system is a system, see, so this saccadic system, I'm looking at this girl, her image is fixed on my fovea. Now somebody from the periphery is coming, that image also has to be fixed on my fovea. Now two people are coming from the periphery, their image also has to be fixed on my fovea. So that is a very complex thing. So that complex thing is done by the saccadic system with vestibulo-ocular reflex. If these systems are not working properly, there will be the retinal slippage and vertigo. In day-to-day life, see, in day-to-day life, you can see this. I'm standing here. This image is fixed on my fovea already. But now the images are popping from this side, from this side. That image also has to be fixed by my brain, and this function is done by the cardiac system. Okay, smooth perceived system. See, when somebody is seeing a sky, that whole the sky is in my fovea, the stationary. But if something just like aeroplane or bird is coming from the periphery and moving smoothly, this is already in my fovea. Now this silly thing is also coming in my vision. So our brain also has to fix that image, slowly moving object. This function is done by the smooth perceived system. So eye has to keep the sky and also the slowly moving object, and this is done by the smooth perceived system with the help of the vestibulo-ocular reflex. If there is a problem, then that is also done by the central cause. Sorry. Optokinetic system. Suppose you are sitting in the car or in the bus and looking outside the window. So what happens is that when you look outside the window, the eye has to keep the constantly moving object in a retina in presence of the already occupied visual field. Means is visual field also moving towards yourself, and we are also moving. So there is constantly changing of the visual field also and our thing also, and it is very complex thing, and that is maintained by the sorry that is done by the optokinesis. See the Sino Darbar, I'm sitting on the car, I am also moving, surrounding also moving. So it is a very complex thing. See, I'm running in the Baneshwar, Everest Hospital. I'm also constantly moving. This whole thing is also moving, and there are something coming from popping here in there. Everything is moving right now. So I'm also moving. Everything is moving. So this complex system is maintained by the optokinetic system, and with the help of the vestibulo-ocular system. Vestibulospinal reflex. See, vestibulospinal reflex. See this complex action. The guy is trying to fall, but the vestibulospinal system has done a reflex contraction of subgroup of muscles and relaxation of the group of the muscles. So the trunk is contracting from one side, relaxing from other side. His vestibulo-ocular system is also contracting from this side, other side, and he is trying to maintain everything. So he's trying to maintain the gaze, he's trying to maintain the posture, he's trying to maintain the graviception. This is very important. So a lot of the patient, when they come to my clinic and they ask, doctor, what is the cause of vertigo? I cannot say. So what? So I have kept this as a this thing chart in my, or as this brochure in my clinic. So I explain to the patient, see all these things: eyes control, brain controls, air control, joints control. If there is any problem in this system, you may feel vertigo. Or if there is any problem in the ascending pathway to the brain, you may feel vertigo. If there is a problem in the brain, you may feel vertigo. So you may feel vertigo if there is a problem in the system, in ascending pathway, in this and in the descending pathway also. Despite that, you may have feel a vertigo when you have a problem in your heart or when you have a problem in your cognitive system. So this has to be patient. There is no one cause of vertigo. The vertigo is multisystemic. So whenever the patient come to my clinic, to my vertigo clinic, and I start examining them, I start to examine from the oculomotor system. So I start examining to the eyes. So they say, doctor, this is not my eye problem. I have come here to treat my vertigo. So I normally tell them the eyes are window to reach to a diagnosis in vertigo. I must be checked. Why? I'm not checking your vision only, but I'm checking your other things in the eye. So we should all know genesis of nystagmus, or why nystagmus occurs. So in normal situation, we know that the two eyes, two ears will send equal push and pull to keep our eyes in the midline. If there is a left vestibular hyperfunction, so the push from the left side will be very less in comparison to the push from the right side. So now what happens is that in left vestibular hyperfunction, the eyes will, because the push from the right side will be more, so eyes will be moving towards the left side. Slowly the eyes will turn towards the left side. This is known as a slow phase of the nystagmus. Okay? But when you try to push, I cannot rotate 360 degrees. So this movement has to be stopped by someone and somewhere. So what does the brain does then? In left vestibular function, when eye is moving towards the left side, the brain calls, no eyes, you cannot move 360 degree. You have to come back to your original position, or you have to come towards the right side again, or to the original position, and then suddenly the eye moves towards the right side. This is known as the fast phase of the nystagmus. And the nystagmus is known by the fast phase. So in left vestibular hypofunction, there will be the right beating nystagmus. So slow phase of the nystagmus is caused by the peripheral system, but the fast phase of the nystagmus is caused by central nervous system. And nystagmus is known by its fast phase. And clinical relevance of this. Why anti-vertigo drugs should not be given for more than 5 to 7 days unless indicated. Why? I'm again going to talk on the when there is a left vestibular hypofunction, suppose, so there will be the less stimulation going from the left ear towards the brain. See, and brain will understand. See, the very less information is coming to me. Hello, other system, other side. You become very, very, very alert. Now you should work more because left ear is not working. Now the other ear will, other system, other component will start to work more, and the brain will tell hello. Left, and this is known as a central compensation. So all the system of the body will be working more, but the workload will be more on the opposite ear because it is trying to compensate this ear. So this ear will be working more. But when we give a and it will take some time. But when you give the vestibular sedative drugs, anti-vertigo drugs, then this will cause a sedation of this ear also and this ear also. So there will be the delay or inhibition in central compensation. So that we normally tell that anti-vertigo drug, until and unless indicated, should not be given for more than 7 days. So now coming to a second part of our presentation about is history taking. Just give me a few seconds so that I'm opening this slide. I'm sorry. I'm opening this slide and we are doing a history taking. Is this slide visible to all?
It is visible.
Okay, thank you so much. So history taking is very, 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 very important. Why? So normally I tell that the history taking accounts for 70, it helps 70% of the diagnosis. If we take very proper history, then it is very high chance that we reach a diagnosis. So it is so sensitive that it will take you at least your diagnosis 70% true. And if you add a clinical neurootological examination, then your chances of reaching a diagnosis is 85%. And the investigation will happen in 10 to 15% of the cases. So if we can do a very proper history taking and clinical examination, 85% of the patient will be done. We can manage this. For me, if somebody asks how much important, slides are not visible. Is it visible? Sides are visible. I'm getting a ping that sides are not getting visible. Is it visible? Kiranji, it is visible. Okay, thank you. So thank you. So if somebody asks me, we cannot start a neurology clinic because we don't have any investigation. Believe my friends, we don't need investigation things in 85% of our cases. We don't need it. We can properly take a history and do a clinical neurological examination and make a diagnosis. So see, throughout the world, 10 to 15% of the cases it is not possible to pinpoint the specific diagnosis throughout the world. So investigation will help you something, but no, but for me, in 90% of my cases, I don't do any investigations. Believe me. So now we should decide, because history is very important, how much time we want to spend on the history taking. If less time on history taking, we can give more time on clinical examinations. So what I have started practice is that I had made a questionnaires which I give to my receptionist, and that receptionist, when any patient with vertigo, she requests that patient to fill this form. That patient will be they will enjoy to fill this form very nicely, because each and everything that they wanted to tell us is mentioned in that form. So that will save my time in history taking. Then when the patient comes to my clinic, I see that form for 2 to 3 minutes. I can make it out, and if I confuse in anything, I'll ask the patient to clarify the things and push it to examinations. That makes my job easy. So this is a form that I use in my Vertigo clinic. So this is a worksheet which is translated in Nepali, and this has got all the information that I want to know. At least it gives me 70 to 80% of the information. And this is a English form of that, because some of the if an international patient comes, or the patient who doesn't know Nepali, so they are allowed, or they are suggested or requested to fill this form. So after that, so what are things that are written in that form? That is very important. So I first like to ask the patient to describe your attack. So the first attack is very, very important. Believe me, the patient will not forget the first attack. Just like we went through a very first attack of vertigo in Baisakh 12 gate 2072, because it was an earthquake, it was a vertiginous to us. So if from 20 years down the road, I'll not forget my first attack. Similarly, the vertigo is earthquake to the patient. You'll never forget his first attack. But sometimes, if the patient will forget his first attack, because it may be 10 to 20 years ago, ask about the last attack. But this also has some fallacy. Let me tell you example. If any patient with Meniere's disease, okay, will come to you. He has been diagnosed as a case of Meniere's disease 5 years back. Then he comes to you and tell, doctor, I had an attack of vertigo, and I was diagnosed with Meniere's disease 5 years back, and again I'm having that vertigo. So sometimes if you ask to the patient, what was your first attack? Can you remember? Can you tell me? And he'll tell you, yes, doctor, that time I was having a severe rotatory vertigo along with the nausea, vomiting, oral fullness, if you specifically ask, tinnitus, and that lasted for 4 to 5 days. And if you ask, so what is your sensation of the vertigo now? Now, doctor, I feel something uncomfortable, dizziness, nauseating thing. And how long it is? It is 5 to 10 minutes. So see, that attack and this attack is totally different. Maybe that time the patient was having the Meniere's disease. Now the patient complaint is of vestibular migraine, which is an overlap syndrome. This also has to be properly asked to the patient. First attack and last attack. It's very, very important. So what are the things to ask? The things to ask we have to have in mind and clarify it in detail. So what are the things to ask? Describe your vertigo. First attack, last attack. Is it constant or intermittent? What is the time duration? What are the triggers? How severe it was? Associated symptoms, and not to forget autological, social, and medicine history. Defined term. This is very, very difficult, because if the patient cannot describe what had happened to them, they will describe them as vertigo. The patient know how to describe headache. Patient know how to describe nausea. The patient know how to describe abdominal pain. The patient can describe fever. But anything that they cannot explain is described as vertigo. because they are not a medical person. They are laymen. So we should be very, because this terminology is very vague, non-specific, and means different to the different people. So we medical person can tell whether it is true rotatory vertigo, it is syncope, giddiness, anything, but that patient cannot. So it is very, very hard to make them tell what you are feeling. See, so what I normally practice is that I give a leading question to my patient initially. So when I tell describe your vertigo, I normally tell listen to me. I'm describing few common type of the vertigos, and you listen properly and tell me whether your feel of the vertigo is out of those or you feel differently. And you must have to understand that different feeling of the vertigo may indicate different disease. So vertigo will not only define one disease but different disease. So you have to understand. So while I give the leading question, the thing that is very, very vague in the patient has to become very smoothly to a physician mind. This we must have to take with a serious account. So I normally ask to the patient, what is your feel of the vertigo? You tell, I normally tell. So these are a common feeling of the vertigo. So one is your vertigo is too spinning type, rotatory type or not? If it is rotatory type, do you feel a vertigo when you are lying down or when you are getting up or when we are rolling into bed for a few seconds? Or does your surrounding spin or you feel that you are spinning yourself? That is subjective vertigo. Does your feeling of the vertigo is a dizziness with headache or heaviness of head aggravated by noise, sound, lights, or stress? Or is your vertigo like that you feel weak or transient loss of consciousness when you are getting up from your chair or getting up from your bed? Or is your feeling of the vertigo is that you are not able to walk in a straight line or you feel that you are wobbling? So these initially gave me some idea. See, spinning to rotated type of vertigo. Okay, this could be a peripheral vertigo. Subjective sense of spinning. This is not too rotated. Maybe it is a central cause. Dizziness along with headache, nausea, vomiting, triggered by light, mobile phone, screen time. Maybe vestibular migraine. If the patient is feeling dizzy or loss of or weakness when he's getting up, maybe postural hypotension. If the patient is not feeling properly, or the patient thinks that he cannot walk properly in the straight line, maybe he's having some problem in his vestibulospinal system. So if I'd ask to the patient, if your vertigo falls in this category, if no, then please explain me what do you feel. So that makes his or her vertigo come. So I want to feel that vertigo, what patient is feeling. That will lead to me to a diagnosis. Then I ask whether your vertigo is constant or intermittent. That is very important. If it is constant, maybe some central cause. Intermittent, maybe some peripheral cause. If intermittent, does it comes in spill? So if it comes in spill, how long it lasts? Seconds? Minutes? Less than a minute? Minutes to hours? Hour to days? Days to weeks? Weeks to month? That will tell me something. If the patient is having vertigo or sense of vertigo lasting for 1 to 5 seconds, could be a BBBB, could be a vestibular paroxysmia, could be a superior semicircular canal descent syndrome. If the vertigo lasts from minutes, seconds to minute, could be a BBBB, could be a cardiovascular cause, could be a panic disorder to the patient. If from minutes to hour, could be a Meniere's disease, migraine associated vertigo, could be a panic disorder, transient ischemic attack, hours to days, Meniere's disease, migraine associated vertigo, stroke, central nervous system problem, vestibular neuritis, labyrinthitis, weeks to day, days to week, vestibular migraine, vestibular neuritis, labyrinthitis, stroke, or some central nervous system problem, drug reaction, stroke, and if it's from months to year, could be stroke, fracture vestibular disorder, like fistula in semicircular canal, ototoxicity, or psychiatric. See, this nasty vestibular associated migraine is everywhere. I tell the vestibular associated migraine should be added from seconds to minute also. This is maybe we are overdiagnosing. We don't know, but retrospectively we are getting a correct treatment. So if somebody asks me what is the number one cause of the vertigo in present scenario, in literature we can find it is a BPPP. But if somebody asks me, I'll tell migraine associated vertigo, because we have a proof in our clinic. We have got documentation of more than 1,650 people, in which number one diagnosis is migraine associated vertigo. Third most important thing that clinch me or that helps me to make my diagnosis is triggers. If we can perfectly or correctly ask this trigger, it will help us to diagnose. Trigger. We can ask to the patient, do you feel a spinning sensation when you change the position of the body or head, when we are getting up from the bed, or we are lying up on the bed, or we are rolling over the bed? The patient says, yes, 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 I get that. And that is a BPPP. If somebody complains, hypotension. Other thing is that when there is a sense of the giddiness or vertigo, when there is a rapid head movement, it could be a BPBP, it could be a vestibular seizure, it could be a post-labyrinthitis and vestibular neuritis. I like to add something in post-labyrinthitis and vestibular neuritis. We know in post-labyrinthitis or post-vestibular neuritis, the patient why they feel vertigo when there is a rapid head movement. See, when it okay, so the patient will come to our clinic, doctor, when I move my head or suddenly when I turn like this, I feel giddiness, lasting for a few seconds. So your diagnosis will be no, it could not be vestibular neuritis, or it could. So we must have to again ask the patient, did you have a history of severe rotatory vertigo lasting for, okay, can you explain your first attack of vertigo? And the patient will say, yes, doctor, 5 years ago, I had got severe rotatory vertigo. I was admitted to the hospital for 4 to 5 days. Doctor, they gave me a intravenous medications. I was there in a hospital for I was there in a hospital for about 5 to 6 days. Then I came back, but I was not that good till 2 to 3 months. Then I'm okay right now. But when suddenly I move my head like this, or I play, or in a jerky movement, I feel dizziness. Why is that? Post-labyrinthitis or post-vestibular neuritis has damaged one side of vestibular labyrinth or nerves. To some extent, there was a recovery, but the recovery was not 100%. Maybe the recovery on this side was 95%. So now this side is functioning 100%, this side is functioning 95%. So when you rapidly move it, there is a mismatch of the impulse. So from here the impulse is coming 95%, here the impulse is coming 100%. So there is a mismatch, and that patient will feel giddiness. This is very important thing to ask that we miss. Walking in the dark room. This patient will complain that they have got a bilateral vestibulopathy due to ototoxicity or anything. So now their balancing system is controlled by only by the eyes and by the peripheral system. So when they sleep, they get up from the bed. Now there only one system is, because it is dark, so one system is not working. Our system is already damaged. Only the peripheral system is acting properly. So when they wake up, they feel dizzy. But when they put on the light, now their another system is will also help them to maintain their balance. They feel easy. So they also feel problem when they walk in a smooth surface, because one system, that is a peripheral system, will not be working. Only the eyes will be working at that time. So that is also very, very important thing to ask. If if the vertigo is triggered by light, sound, menses, then we could think of a mini series. Migraine. So if loud noise, change in pressure, it could be a lateral semicircular canal fistula or superior canal descent syndrome. This is very important. We have seen a lot of the patient who comes to us, not a lot, but at least in my practice, 10 to 15 patient who had come to me with the complaint of, doctor, I don't feel problem, but when I go to toilet and sometimes on active strain, I feel vertigo. And the diagnosis is a lateral semicircular canal fistula. And we have treated those cases. So when anything is stress, it could be a migraine or psychiatric moving stress. So in my practice, I see a lot of the patient with vestibular migraine. So there is a seasonal variation of those patients, especially the bankers. When there is a closing time, they have to work so hard in their laptops, in their mobile phone. So the stress is so high, they come, they feel a vertigo, so they come. So stress is also one of the most important factors. And if you feel vertigo when seeing moving things, it's like the patient goes to the hospital, go to the movie theater, and they watch Fast and Furious. If they feel vertigo at that point, and repeatedly there is the same history, doctor, when I watch television, I don't have a problem. But when I go to movie theater and watch a fast movie, I feel vertigo. So diagnosis of vestibular seizure. We also have to ask the associated symptoms like oral fullness. If there is oral fullness, it could be the vestibular, it could be the Meniere's disease, and it could be perilymph fistula, earache, otitis. If the patient comes, doctor, I am having vertigo, but before that I was having some URTI, upper respiratory tract infection, earache, and I'm having this. So could be a otitis media, and leading to labyrinthitis. Sometimes the patient gives, doctor, I have got weak fullness of the air and I feel vertigo along with the nausea, but it will last for 10 to 15 minutes. Then you may think it could be a typical Meniere's disease causing the pain around the ear. If there is a facial weakness and vertigo, then we should think about the heart gesture. Then we should then we should do a thorough examination of the pinna if there is any vesicles around that. But sometimes we should be if you rule out everything, you don't see anything, there is facial weakness and vertigo, then we should think of the acoustic neuron and send the patient for imaging. Similarly, in headache also, if the patient has a past history of the headache, family history of the headache, then and associated now with the vertigo, then we should think about the migraine associated vertigo. Hearing loss. The hearing loss, if the patient is having vertigo and hearing loss, it could be a Meniere's disease, it could be perilymph fistula. But I need to highlight one thing. The patient will tell doctor, I'm having so when the patient comes, okay doctor, I'm okay, he comes to our clinic and we ask to the patient, what is your problem? He says, doctor, I'm having vertigo. So then we'll ask all those things, how long, so what is the duration, you describe your first attack, everything. Then we'll have, do you have any oral fullness, do you have any hearing loss, or do you have tinnitus? Then he'll say, yes, doctor, I have hearing loss, also tinnitus also. Then we label the patient as the Meniere's disease. But if we take a proper history, then that hearing loss may be since so many months. The patient is 55 years old, 60 years old, so he had some degree of the presbycusis. So there could be a hearing loss, there could be a tinnitus. The most important thing that we have to ask in the Meniere's disease is that whether the hearing loss is preceded along with or followed by tinnitus, oral fullness, or hearing oral fullness, tinnitus, and hearing loss or not. Not if the patient doesn't having the Meniere's disease, or if the patient is only having the hearing loss and vertigo and he is having the Meniere's disease. So all the symptoms have to be correlated. That we will discuss later. And if the patient is having the diplopia, dysarthria along with the vertigo, then we may think it could be a central cause. And the vertigo associated with the nausea and vomiting are most likely due to the peripheral cause. Then we should have other relevant history. If there was a history of vestibular upper respiratory tract infection, air discharge, could be a labyrinthitis, vestibular neuronitis, if hearing is intact. If hearing is not intact, then if the hearing is intact, it is vestibular neuronitis. Not intact, it could be labyrinthitis. If there is a head trauma, the patient could have bilateral BPBP, always think interaction. If somebody has slapped him 2 days ago and now he is having the dizziness or wobbling sensation, it could be perilymph fistula. If the patient has got history of diabetes mellitus, hypertension, smoking, cardiovascular cause, or the cardiovascular factors leading to some problem. If the patient is having the depression, anxiety, if the patient is having antidepressant drug or recently developed this, then it could be a psychogenic vertigo. If the patient was admitted in ICU or in hospital and given some autotoxic drug, we should think of bilateral vestibulopathy. And if there's a history of migraine headache or family history of migraine headache, then we should be really suspicious about the vertigo, migraine vertigo. And autological history that we have talked, we should be always elicit the autological history. Then all this cardiac history, endocrine problem, this thyroid problem, diabetes, because this thyroid problem and diabetes problem, see, diabetes mellitus, it causes a peripheral neuropathy. When there is a peripheral neuropathy, there is a very less information coming from peripheral system to the brain. So the patient will have some degree of dizziness, but that degree, that type of the dizziness has to be identified. Whether that is true rotatory or unsteadiness or any other problem, we should also help. We should be also able to identify the autoimmune cause and psychiatric cause also. That is very important. Medications, the hypertensive medications, autotoxic drugs, which has to be very properly thing. So now one of the most important, why are we so worried about seeing the patient with vertigo, is that we think that we may miss any sinister pathology, and that if we miss that and the patient will have problem, we may land up in problem. So because of that, we are so scared. So what are the red flags in neuroautology? If any problem, if the patient with vertigo have any other associated neurological signs, it's like dysarthria, diplopia, any other things, or the patient is having new type of the headache, patient is having vertical nystagmus on examination, and the condition is deteriorating as minute by minute or hour by hour, then we should think that this patient needs some urgent intensive care. And at that point of time, we should refer that to the patient. But if these things are not happening, then we should not be worried about taking care of the patient with vertigo. So if we remember some characteristic feature of the central and peripheral vertigo, it will be easy. Peripheral vertigo are usually sudden and paroxysmal. Central type of vertigo are usually slow. They comes very mildly and slowly. But peripheral vertigo are very severe. And peripheral vertigo are usually the paroxysmal, and central vertigo are constant. Head movement, okay, central vertigo are sometimes precipitated by head movement, but peripheral vertigo are usually precipitated or exacerbated by the head movement. The autonomic symptoms like nausea and vomiting are very severe in peripheral vertigo, but not in the central cause. Nystagmus are usually horizontal, sometimes rotatory in peripheral, but it may occur in any direction in central cause. And if there is a absent of the associated other neurological findings, is usually peripheral. And if there is associated neurological finding, it is a central cause. So all this history and clinical finding has to be properly record kept, because we see the patient once, we talk to the patient, we remember that patient right now and we write the drugs. But second times when that patient comes, we forgot all the findings. So record keeping in the management of the patient with vertigo is very, very important, because it will tell us what was the status of the patient, how he is doing, what was his complaint then, what is his complaint now. This is very, very important. What was the sign, what was the sign now? This is very, very important, because it helps us a lot. If we see patient on new OPD cards or clinics tickets every time, that is a mess in the management of the patient. So record keeping in institution, in corporate hospital, there is always a record keeping, but in private practice, there is less record keeping. But in patient with vertigo, we should do a record keeping. That is a very important thing. That's what I learned from my mentor. So thank you all. And we thank you all. So today it was quite short. We had only discussion on a basic concept, because this is a series of neuroautological seminar. So next session will be on 8 June, where we will be talking about clinical examination of the patient with vertigo. So thank you all. We have any questions? And if we have questions, then we'll take the questions. So, hello. Hello. Dr. Sandeep, you are there? Okay, how can I see the questions? I'm not able to. I can see a chat. Oh,
There are no questions as of now, sir.
okay, there's
Probably
no
need
question. That's great.
Yeah, probably need to ask. There's one question which has come. Have you come across any overlapping in the diagnosis?
Yeah, so we have, can you recording? Yeah, Dr. Sunil Kumar Agrawal. Yeah, I think yeah, we will definitely provide you recording. Have you come across overlap diagnosis? Yes, Dr. Arun. In my vestibular, in my Meniere's disease, 60% of the patient they have overlap syndrome. Dr. Geeta, diagnosis of psychiatric vertigo or doji. So, yes, Geeta, we do have a different terminology for that, and we will be discussing that when when we'll be discussing on the management of the patient with the common cause of the vertigo. Yeah. So the vertiginous sensation, as I want to tell you, is that the sensation has to be we have to feel that sensation. Until and unless we feel what the patient is feeling, we cannot diagnose or we cannot diagnose a vertigo. So leading question to the patient is very important, because if we don't lead, and if you don't give a leading question, the patient will take you nowhere. He will take you from Neupane to Maharajganj, then back to Chakrapath. He'll take to airport, and finally you will not come to a proper thing. So that is very important. We should lead our patient. We should give a leading question, because this is my practice from, I think, 7 years from now. So until and unless we give a leading question to the patient, they will take us nowhere. We'll be having vertigo after some time. The patient has got so long history to say, because I normally get a patient who is suffering from vertigo from 5 to 6 years. So they have all the story of 5 to 6 years to tell to me. I went to this doctor, to this doctor, to this. I have done all the investigation. So the most important thing is that we should give a leading question to the patient about their feel of vertigo, and we should feel their vertigo. Yeah, early and there is from Jivan Bania, early and late phase of nystagmus. Yes, Jivan, this is early and late phase of nystagmus. Yes, what we talk about is a vestibular hypofunction, which is usually after irritative phase, there is a hypofunction phase. And we were talking about the hypofunction. If we talk about the irritative phase, that will be just reversed. And the management changes. Yes, you are correct. Management changes, because in irritative phase, normally we try to give a vestibular sedative, but when it is a hypoactive phase, after 3 to 4 days or hypofunction test, we like to rehabilitate. So the management is totally different. You can give a anti-vertigo drug or vestibular sedatives when it is in irritative phase. It will help. But when you give that in a hypofunction stage, it will aggravate the condition. Yeah, true. Neeraj, does anti-vertiginous drug alter the presentation of clinical feature of disease? If yes, how to overcome it? For me, it doesn't change this, because for me, most important thing is a history. I was telling the history. I believe the history for my patient 70%. So I think if I can take history correctly from the patient, my diagnosis is 70% correct. Then I rely only on my clinical examination for about 15 to 20%. I first rely on my history. So I spend so much time on history taking. I normally tell them to fill the form outside my clinic, which my trained assistant will help them to fill, will guide them, because they are so sometimes they doesn't know. So when they come inside also, I'll spend at least 10 to 15 minutes with them. So my one vertigo patient, after they enter my clinic, is roughly about half an hour. Sometimes it is 45 minutes. Okay.
So there is a question on overlapping symptoms. So how you came across?
Yeah, I answered.
Have the
Arun.
yeah.
So most of the overlap symptoms, what I have come across is initially it is a Meniere's disease, and after sometimes there is overlap of the vestibular migraine. So we should be taking the history of the first attack that was 2 to 3 years ago or 1 year ago. Now also the patient is coming with the complaint of the vertigo, but we should be able to elicit what is your feeling of the vertigo. So patient will definitely tell those two vertigo are definitely different. That is very important thing. And sometimes you see this in post vestibular neuronitis and overlap of BPP. You should be very careful in this also.
So there is a question.
Sometimes the patient came with the history of BPBP, query BPBP, but patient took a medicine and this Hallpike won't turn be positive. What do you think in these circumstances? I think I answered this question in last webinar also. I normally, when the patient comes to me, I believe on the history. Still, I believe on the history. The history has to be so extensively explored, and I'm convinced that this patient is having BPBP, and the patient is not having, if the disulfide test is not positive. Last webinar, we talked about why disulfide tests are not positive. Because the disulfide tests are sometimes not positive because the patient is not cooperative, and the angulation, then speed of rotation, speed of movement is not that perfect. So there are a lot of drawbacks of that. So for me, if somebody is taking anti-vertigo drugs for 2 to 3 days and coming to me with the classical symptoms of BPP, I normally get, for me, I normally get disulfide positive if it is a, but it depends upon the amount of the otoconia that had dislodged from utricle and goes to the semicircular canal. If there is only minimum amount of the otoconia, despite taking anti-vertigo drug or not taking anti-vertigo drug, it may disappear. At that time, I'll write the diagnosis. The history is likely of BPPV, but now inactive. But if the patient has a significant amount of otoconia causing the symptoms, I don't think that anti-vertigo drugs will max the clinical finding. There is another comment, please tell us real cause of vertigo, or is there? Yes, Sriti, thank you for the question. We are coming that because it is a very, very, very nice thing to talk, because in my presentation this time also I have shown that because every patient we normally diagnose as a either Meniere's disease or cervical spondylosis and treat as a cervicogenic vertigo. So we'll talk about on that on subsequent, but to tell you, right, because the cervical spondylosis or the causing the cervical vertigo, it has to be able to feature the posterior column first, not true rotatory vertigo. I don't believe true rotatory vertigo is caused by the cervical spondylosis. So true rotatory vertigo is very important for me.
So there is a question on do the age of patient help in diagnosis of vertigo?
Yes, yes, why not? The age of the patient, see, just like sometimes the patient comes to us, 60 years of the old patient, he'll give us the history that when I suddenly lie down, I get a dizziness. But we should be very, very important. We should be very properly asking to the patient. 60 years old patient, uneducated patient, it is too tough to get history from him. It is too tough. We all know, and we have so many 20 to 30 patients waiting for your consultation. At that time, you taking the history from that patient is very, very tough. So, but if we do a proper neurootological practice, then we should be eliciting the history properly. That is very, very important. For me, 60 to 70 years old patient, if it is having diabetes, if it is having anti hypertensive drug, the most common cause that I have found is either PPP, or second thing is the peripheral neuropathy causing the disequilibrium than BPP. And other thing is that as the age goes up, similarly, there is a presbycusis, means age-related hearing loss. So there is age-related vestibular hypofunction. We have to understand that pathophysiology also. For that, the best treatment is a rehabilitation, training of the training exercises that has to be given to the patient. So we don't think that only the hearing loss is due to age. Hypofunction of the vestibular system also happens due to the age. So for hearing loss, we give a hearing aid. For hypofunction of the vestibular system, we have to give a vestibular rehabilitation to the patient. Does prolonged abnormal position of the head induce peripheral vertigo? Yes, we talked in last webinar also. The prolonged abnormal head position is one of the cause of the BPPP. So when the patient is there in a dental chair for prolonged period of time, right now we are in lockdown, we are sleeping, we are lying down in the bed, so the incidence of BPP has already increased. So we are getting a lot of telephonic the consultation on that.
Sir, there is a question from Dr. Nikita. How to differentiate between BPPV and vestibular neuronitis?
Okay, Nikita, it is vestibular neuronitis and BPPP. See, if you talk about vestibular neuronitis, there is a 20 to 40% of association between a BPPP and vestibular neuronitis. Okay, but if you talk about the classical attack of a vestibular neuronitis, the vertigo will be it will be two rotatory vertigo lasting for at least hours to days, associated with nausea, vomiting. And the patient, when you see the patient with the vestibular neuronitis, you can tell by seeing his or posture in your inpatient department. He'll be lying so still, and his head posture will tell you which side of the vestibular neuronitis is having. So, but in BPPP, the classical history will be the positional vertigo, either in act of lying down or act of getting up or while rolling in the bed, and it will be lasting for a few seconds. But sometimes the history may be very misleading. The patient will tell that, the patient of BPPP will tell you, doctor, if you ask how long is the vertigo, it is throughout the day, he will tell you. The patient with BPPP. But again, you should specifically ask to that patient. You should tell some patient will have two rotatory vertigo for only for a few seconds, but sense of the unsteadiness or sense of the post attack will last for days. Is your vertigo two rotatory vertigo will last for days, or only rotatory vertigo will last for a few seconds, and sense of instability or post attack syndrome will last for a day? And that patient with BPPP will tell, doctor, the two rotatory vertigo is only for a few seconds, but I feel so unsteady and unstable throughout the day. So see, that is not vestibular neuronitis, that is BPPP. Vestibular neuronitis is two rotatory vertigo that will lasting for days. So this will help to differentiate. But if the patient had an attack of vestibular neuronitis in the past, has got very high chances of getting BPPP in future. So we should ask about the last attack, we should ask about this attack. This will help you to differentiate. Any other questions?
I think, sir, there are no more questions now.
Okay, thank you, Dr. Sandeep.
I think we have come to the fag end of today's meeting.
True.
So, on behalf of entire ABIT international business team and the medical team, I want to thank sir for you taking time from your busy schedule and enlightening us on uh, the phenomena which looks little simple, but actually it's very complicated. So thank you very much for that. And I also want to thank all the delegates for joining us today on a very important topic, and also want to thank my team from Abbott, which is Amit, Ashutosh, Kiran, and Sunil, for making this wonderful enlightening session a reality. So thank you, all of you, and I think we will close now. So thank you very much once again.
Okay, thank you, Dr. Sandeep, and thank you all about team, and thank you all, and Eid Mubarak to everybody. Thank you. See you again on next episode.